Hello, and welcome to another Spotlight the Science, where we get to meet the researchers who have received research funding from the American Diabetes Association. My name is Marlon Pragnell. I'm Vice President of Research and Science at ADA, and today I'll be speaking with a rising star, Dr. Layla Abushamat. Dr. Abushamat is an assistant professor in medicine at Baylor College of Medicine in Houston, Texas, and she received both her MD and Master's in Public Health degrees from Tulane University in New Orleans, Louisiana. She's doing very exciting research on cardiovascular disease and how it relates to adiposity and in type 2 diabetes. Welcome, Layla.
Thank you so much for having me.
Tell us a bit more about what you're doing in this area.
Yeah, so with the ADA, I've been able to look at how fat tissue and fat tissue distribution in people with type 2 diabetes may relate to heart function. I actually just recently graduated from fellowship. I say recently, but it was a few years ago, 2 or 3 years ago. I did my fellowship over at the University of Colorado under Dr. Jane Roosh. And while I was there, got very interested in her research where she looked at the effect of exercise training on people with diabetes and how it can be used to prevent heart disease. And they were looking at also heart function in that. And so within that, I've always been interested in fat tissue and kind of fat heart crosstalk and how we can use fat tissue and where it is in different areas of the body to predict future disease. And we know that people with type 2 diabetes, even though it might be even uncomplicated type 2 diabetes, have some signals for having what we call subclinical heart failure, which basically means that it isn't overt heart failure where you have symptoms, but it is the beginnings of what could become heart failure. And people with diabetes are also at higher risk of getting heart failure. And so with all that in mind, I was wondering, can we use fat distribution as well as the fat hormone adiponectin to predict those that might be at higher risk for heart failure and see if exercise training can be something that we can use to prevent that from happening or kind of curtail that from happening.
Interesting. So you said fat distribution, and I know that you're looking at both visceral fat and subcutaneous fat, and that these may have a different effects on the body. Could you describe more about what that is and what does subcutaneous versus visceral fat look like?
Yes. So visceral fat is the fat that's in our organs or around our organs. A good example of that is fatty liver. A lot of people may be more aware of that term in general. And then subcutaneous fat is the fat that's just right under the skin. And in general, that fat is considered better than visceral fat. Visceral fat is connected to poorer outcomes and carries an increased risk for future cardiovascular risk. And so I'm interested in looking at how that kind of the difference in that distribution of fat. So we talk about people who have more central adiposity or fat that's distributed in kind of the central area of your body and how they may have a higher risk. And so whether we can use exercise training to change that, and whether also that impacts how your heart is currently functioning and if you have subclinical disease. And we measure heart function in our studies using MRI. But in the past, we've also done echocardiograms. And so I'm very happy to have joined Dr. Roosh's lab because they've performed numerous studies on this. And so part of my project was to kind of bring together all the different studies that they've done before and kind of use that to power my research question, which is looking specifically at the fat. And so far, we've noticed that even at baseline, that actually obesity seems to be driving much of the heart structural changes that we see, that regardless of if you have diabetes or not, obesity seems to be leading to more arterial stiffness. However, when we look on MRI, we do see some what we call increased pulse wave velocity. So arterial stiffness in the ascending aorta, which is one portion of your aorta, only in people with type 2 diabetes. So diabetes does add to it, but that obesity seems to be driving that risk initially.
Wow. So yeah, you said pulse wave. I know that these scales that are available commercially, where you get this kind of heart health and pulse wave velocity. Is that what you're referring to, where you have this kind of a good score or a bad score there?
Yeah, so there are different ways to measure arterial stiffness, and pulse wave velocity is traditionally actually measured by something called a sphygmocore. So we're actually measuring it in different ways. We are looking at it with an MRI. We're also looking at it with sphygmocore. We're working with our bioengineering department, and they help us with kind of measuring it with all these different cardiac modalities. So it is actually more advanced than the ones that you see commercially available. And we actually find that when we do it with these MRI techniques, that's when we can see these differences in people with diabetes. But, pulse wave velocity, I think like you said, it's kind of a hot topic, hot word, because in general, it's something that, is a quick way to measure arterial stiffness in people with diabetes. And arterial stiffness is important, and vascular stiffness in general, because it can kind of predict your future risk of heart disease. And it's one way to look at heart function and heart disease risk as well. And we do see that in general, the patients that the participants that we are studying are people with uncomplicated diabetes. And what I mean by that is that they don't have any complications relating to diabetes. The traditional ones that we look at are microvascular complications. So when diabetes affects your eyes, your feet, and your nerves. Macrovascular complications are things like your heart. So these are all people who don't have any complications. They don't have any pre-existing heart disease or anything like that. And all of them have A1Cs that are less than 9%, and they're not on insulin.
That's interesting. So what you're saying is that reasonably healthy people then, for example, whether they have increased adiposity, visceral adiposity, then are kind of likely to have some very early stages of cardiovascular disease that really kind of, if not taken care of or not kept in check, could get worse over time and then lead to more kind of clinical outcomes, right?
Yes, and that's why I became very interested in this area. So people with diabetes are at a higher risk of heart disease. I mean, heart disease is a major contributor to morbidity and mortality in the US, but also in people with diabetes, they have a higher risk of heart attacks, strokes, but also, like I mentioned earlier, heart failure. And so why is that the case? And when we look at, I mentioned this exercise training. Why am I interested in exercise training? When we look at people's cardiorespiratory fitness, and that just basically is a measure of how well you can perform activity, how well your body uses energy or is able to produce energy for you. And so we measure that by something like a VO2 peak, and we measure it actually doing something similar to what we consider like a stress test. And so you put people on a bike or on a treadmill and you measure it. And what we've seen is that in people, even with recently diagnosed diabetes or uncontrolled diabetes, they have a lower cardiorespiratory fitness than people without diabetes. And then on top of that, women have an even lower cardiorespiratory fitness than men, and women with diabetes have the lowest cardiorespiratory fitness. And so cardiorespiratory fitness is actually a great predictor of morbidity and mortality in the general population, but also in people with diabetes. We know that in people with diabetes, those who have higher heart events in the future tended to have lower cardiorespiratory fitness. So trying to increase that cardiorespiratory fitness is, a major goal of ours, but also why is it low in people with diabetes, and what can we do to try to increase that? And, unfortunately, people who have diabetes tend to have kind of lower participation in physical activity, less participation in exercise. And there are a lot of barriers to that, which I know it's a big topic for the ADA to kind of address barriers for people with diabetes. But why is it the case from the body standpoint, from the system standpoint? And, the heart is a big player in this, and one of the reasons why I'm really interested in the heart, and also how fat communicates with the heart. But also there are so many other systems at play that contribute to both how the heart talks to fat, things like the mitochondria, things like the lungs, how blood flow. So that's when we were talking about the arterial stiffness. And so it's been really great to be able to take all of these past studies and the data from past studies to try to answer some of these questions and expand them. And then my current work actually with the ADA, so what I mentioned was with type 2 diabetes, but my current work with the ADA, I just recently got funded with a junior faculty award to look at this same question in people with type 1 diabetes and being able to compare it to people with type 2 and to see what signals we have out there. And the great thing is with this too, is that, the earlier, I mentioned this, and I'm not mentioning all this to scare everyone, because I know, I'm saying it's uncomplicated diabetes, and it's even people who are recently diagnosed with diabetes. But the great way that this is, very helpful for these people is that by knowing about this sooner, we can impact, prevention efforts, and we can try to prevent it earlier. And exercise is a great way to be able to do that.
I mean, what you mentioned there is so important. This is early stage. This is very early. You're seeing these very early preclinical and clearly very reversible. So, and you're mentioning also too that you're looking at this in the context of exercise. So when a person with type 2 diabetes, for example, exercise, they have visceral fat, they have subcutaneous fat, and so do we see then that as they exercise that we see an equal loss of visceral and subcutaneous, or how does that work? And then do we see that then a reversal or an improvement of the cardiorespiratory fitness as a result?
Yeah, so far, and we haven't completed the study completely, but so far we see that we don't see any changes in fat distribution after a 3-month exercise intervention. And in general, exercise is not considered a therapy for weight change. Like, it's not considered a therapy for weight loss, and it's great therapy for weight maintenance. But with exercise, what you're doing is you're trying to hopefully improve your cardiorespiratory fitness. You're trying to improve your mitochondrial function, improve not your muscle function, but also hopefully gain some, potential lean body mass. And so that's one of the things that I'm hoping to look at going forward as well, is whether we see lean body mass changes despite not seeing any changes in the fat distribution.
Maybe it's just that 3 months is not long enough. Maybe you need more time. But I mean, clearly exercise is a kind of a core lifestyle aspect to kind of maintain good health across the board. I know that we're having these really very exciting new therapies, drugs that come out. For example, we have the SGLT2 inhibitors, we also GLP-1 receptor agonists. How are those impacting on the adipose heart connection, so to speak? And can people use those to kind of jumpstart their improvement in cardiorespiratory fitness?
Yes. So these are really exciting therapies, the GLP-1 receptor agonists and the SGLT2 inhibitors that have come out in the last several years. And in particular, the exciting part about them is that we have had cardiovascular outcomes trials that have shown that some of these agents are actually protecting your heart and cardioprotective, or what we consider cardioprotective. And when it comes to GLP-1 receptor agonists, we now also use them for the management and treatment of obesity, so for weight management, and they can lead to substantial weight loss. And by doing so can really affect, your weight distribution, as well as improve, the functioning of your heart, and has been shown to improve the functioning of your heart. And then when it comes to SGLT2 inhibitors, it doesn't necessarily lead to weight loss, but it is, like I mentioned earlier, can be cardioprotective. But we also use them nowadays as treatment and therapies for people with heart failure, as it can reduce heart failure hospitalizations in people with and without diabetes. So even just having heart failure, you don't have to have diabetes, and we see this improvement. And so the use of both, I think, is important in kind of this discussion of obesity and heart disease and heart function and diabetes, and heart failure and diabetes, because like I mentioned earlier, obesity seems to be driving the primary difference in structural kind of in heart function, but diabetes also leads to more arterial stiffness as well. And so let's say that we have someone with uncomplicated diabetes, we know that they're at higher risk of having future heart failure. You do want to potentially start them on an SGLT2 inhibitor if you see that signal. Another thing is if they do have excess weight, and we know that we can impact their blood sugar control as well as help them with that weight loss by starting them on a GLP-1 receptor agonist, it's both of those agents, just starting them can impact the heart and impact kind of the adipose tissue and lead to just a healthier association between the two and a healthier relationship between the two. So they're, like you said, game-changing agents. They're wonderful agents. And I'm so glad that we have them available and that we're going to be having a lot of options available in the near future, hopefully. But like you'd mentioned earlier as well, access to those medications it's very difficult right now for a lot of people to be able to access them. There are barriers to that. And exercise and diet are still the foundations of our therapy for people with diabetes and shouldn't be neglected. And these medications are just, like we called them, they're tools. And so they're helpful, but they're always helpful on top of exercise and diet.
Yeah, at the core is nutrition and exercise of a healthy lifestyle. That's obviously the key, and then you can layer on whatever else is necessary. One thing that strikes me is all the crosstalk that goes on between organs. We have the pancreas. We have insulin. We provide insulin as a drug. We're hearing now all the exciting news around incretins, all these signals that come from the gut and speak to other parts of the body, and we're seeing amazing things there. And now, signals coming from the fat, the adipose tissue, and so speaking to the heart and other parts of the body, and so on. Do you foresee the future therapies coming from maybe signals coming from the fat tissue?
Yeah, so it's interesting you say that. So I'm an endocrinologist, and when I first became very interested in diabetes, I asked all my mentors when I was in high school. I was like, well, who's the person that deals with that? And they said endocrinology, and I was like, well, that's a hormone specialist. So what does that have to do with anything? What does that have to do with adiposity and obesity? But the fat is also an endocrine organ, and it releases hormones and it releases factors that impact the rest of the body. A hormone is anything that is a substance that's released that can communicate to the rest of the body and notify the rest of the body of kind of what's going on and what needs to be done. And so, it's a very exciting time. We already see the incretins, the GLP-1 receptor agonists are part of the incretin therapies. But also we have medications like the thiazolidinediones, pioglitazone, is one that can impact the fat and actually, be able to adjust the kind of the fat milieu. And that's one that we've actually studied in the past before. We studied its sister agent, rosiglitazone, and actually saw that in people with prediabetes, you can improve their insulin sensitivity and insulin function. And you do see some changes in adipose tissue distribution. Whenever you give that medication, you typically see a increase in subcutaneous fat and a decrease in visceral fat. So visceral fat's the bad fat that we talked about earlier. And so we already have some therapies that are working on that as well. And the GLP-1 receptor agonists also, just by nature of weight loss, do impact the adipose tissue. So it also is, even though it's not directly, acting on a hormone like adiponectin, which is the most abundant hormone secreted by the fat tissue, it still has an impact on kind of all of that crosstalk as well. So I do look forward to the development of more therapies. And one of the things that I'm really excited about in my current grant with my current award with the ADA, looking at patient or participants with type 1 and their hearts and fat tissue as well, is I have the opportunity to work on obtaining metabolomics and proteomics on these participants. And by doing so, we can look at kind of metabolites and proteins that are involved in this heart fat crosstalk. And we can also analyze the pathways that they're in. And by doing so, we can identify things like other biomarkers that we can use to, something that we can measure and predict future risk, but also pathways that we can target for future therapies too.
That's absolutely fascinating. Yeah, I mean, it's great that you're actually looking both at type 2 and type 1, because I know, with type 1, we're also seeing a large amount of adipose tissue, obesity, and so on in the type 1 population. So it's very important to make sure that we understand, what's happening there, and also to ways of reversing that, and how to be most effective there. One last question before we kind of end this really fascinating discussion. We hear also a lot about bariatric surgery, where people actually lose a tremendous amount of weight as a result of kind of clamping off some of the stomach. Do you see cardiac improvements there as well? Are there major changes in signaling and so on? Is it improved cardiovascular fitness, or what are you seeing there?
Yeah, so I don't know if the cardiorespiratory fitness has been studied in particular, but with bariatric surgery, it's our most effective tool for weight loss. It leads to the greatest percentage in weight loss, and it can lead to type 2 diabetes remission in some cases as well. And just by nature of the weight loss and leading to type 2 diabetes remission, it just does also improve your heart function and improve your future risk. It is an excellent tool, and it's been shown to be an excellent tool, particularly in people with type 2 diabetes who are obese. And then thankfully, we also now have these medications like GLP-1s and the dual incretin therapies like tirzepatide that can also lead to drastic weight loss that's almost to the level of that of bariatric surgery. And then that post-bariatric surgery time period, we've kind of talked a lot about weight loss and weight changes, but weight maintenance is something that's very difficult for a lot of people, whether you do have type 2 diabetes or not. It's just something that's in addition to, kind of trying to figure out how to keep things stable. And weight maintenance is very difficult. And oftentimes we see after bariatric surgery that some people will gain back some of the weight that they lost. And so these incretin therapies have been used now in the post-bariatric surgery space to help kind of taper that and keep that from happening. And so I think this area, like you mentioned, it's an exciting area because every few months we hear of a new update. It's something that is an exciting area to work in, just this cardiometabolic space, because I'm really hopeful that we'll have more therapies available to people who are suffering from both obesity as well as type 2 diabetes, but also more tools and information for them so that they can figure out what is my risk, my future risk, what knowledge can I, gain about my body based on different markers that we can check in my blood, or based on different tests like measuring my aerobic fitness. Is there something that I can do? So in a way, it brings the power back to the patient, the person with diabetes, and gives them the power to be able to impact their future and impact their future risk when it comes to cardiovascular disease.
Definitely. Absolutely fascinating discussion. This is clearly very important, very topical. Cardiovascular health is so important for people with type 1 and type 2 diabetes. And we're so grateful for the work you're doing, all the research you're doing now, and also looking forward to future really great developments and great research and great data coming out on how best to kind of improve cardiovascular fitness and prevent cardiovascular disease in both type 1 and type 2 diabetes. Thanks so much.
No, thank you
for your time.
I really appreciate it, and I appreciate all the support from the ADA. I wouldn't be able to do what I do without their support.
Well, we're very happy to have you working on such great research. Thanks so much.
Thank you.